and welcome. On behalf of Jagsonpal Pharmaceuticals Limited, I welcome you to this Scientific Sangam 35, which has been organized by ISOPARB Prayagraj. It is in association with Allahabad, Amravati, Yavatmal, and Solapur Obs and Gynae Societies. The topic today is endometriosis and Enigma. A very, very interesting topic for all of us. Welcome to the faculty present with us today and the attendees who are joining us. President of ISOPARB Prayagraj, Dr. Ranjana Khanna ma'am. I welcome you, ma'am. Ranjana Khanna ma'am is also the National Vice President, FOGSI 2017, and the ICOG Governing Council member currently. And ma'am is the candidate for FOGSI President election. Best wishes to you, ma'am. And we hand this over to you now.
A very good evening to everyone. Yeah, so first of all, before we begin anything, it's always Lord Shiva for me. So please let us start with Mahamrityunjay Mantra. At the outset, I welcome everyone, all the faculty, all the learned experts, and the delegates to this webinar, because endometriosis has always been an enigma. And I think since times immemorial, we have been dealing with this enigma and talking about this. So we have lovely talks lined up today. At the outset, it's a very, very warm welcome to Dr. Suvarna Khadilkar. She's a wonderful lady, and she is going to be the Secretary General of FOGSI this very January in Mumbai at the AICOG. And currently, she is the Deputy Secretary General of FOGSI, and a extremely level-headed and a very, very focused person. She is Professor and Head of Department OBGYN and Consultant Endocrinologist and Gynecologist, Mumbai Hospital Institute of Medical Sciences, and Deputy Secretary General FOGSI. I've just said that. She was Vice President 2022 to 24 and Secretary MOGS 2021 to 22, and currently she is the President of MOGS. Editor Emeritus, Journal of OBGYN, Treasurer FOGSI 2018 to 21, President Indian Menopause Society 2017, President Association of Medical Women of India, Mumbai branch, editor of 12 books, delivered many orations, keynote addresses, invited lectures, and she has got so many lectures, orations, and awards and everything to her credit. So I welcome you, Dr. Suvarna Khadilkar, and you please give us your words of wisdom and bless this webinar.
Thank you so much for inviting me here, Dr. Ranjana. I think Ranjana has been doing wonderful job. First of all, I like the title of this particular, webinar, that is Scientific Sangam. I remember I had attended your conference called Scientific Sangam and Double S. So that was a beautiful memento, and I like this term. But here the Sangam is happening of 4 different societies. You have Allahabad, then Amravati, and Yavatmal, and Solapur societies, and you are having this ISOPARB along with them, ISOPARB Prayagraj. So I think ISOPARB is also doing great work. I can see so many of the dignitaries whom you have invited. I can see Dr. Sanjay Gupte as a chief guest, Dr. Sandeep, who was my student, as a guest of honor. I can see the, teacher of teachers, Dr. Manju Varma, who is here joined, and I think I met her, and I can see how dignified and how great person she is, and also the various scientific sessions that you have. You're focused on the panel on endometriosis, infertility, and endometriosis and new drugs, and all the presidents and secretaries of all the four societies have participated in a fantastic academic session that you're having. And always endometriosis, we look at it as a disease with enigma. And the symptomatology, as a student, we learned and we teach our students that the symptoms are 4 Ds, and these are all different pains. So, dysmenorrhea, dyspareunia, dysphagia, and difficulty in conception. So these are the four collection of various symptoms as a syndromic presentation of endometriosis. And I can say Dr. Milind Shah, who is going to have a panel on endometriosis and infertility, and a whole galaxy of your panelists who are going to have a wonderful discussion, Dr. Anuradha Khanna. So I really think, Ranjana, you have gathered a lot of brains together here, and I'm sure you are going to have a very good brainstorming session for all. And I'm sure delegates are going to really be very happy, and they will go back with a great academic feast. So also you can see Dr. Uma Jaiswal and Dr. Parul who are there, and Amita has been coordinating with me. I think I was giving her all. She's telling me, ma'am, have you got your... She has been really coordinating very well. And thank you so much, and wish you all the best.
Thank you so much, Suvarna, for the lovely words. The scientific expert of this whole webinar is Dr. Manju Varma, and she is past president UP chapter of OBGYN, and she is ex-HOD MLN Medical College, a teacher of teachers, and she has a bank of knowledge. And Manju Didi, we look forward to your advice always, and you are welcome in this webinar. And now, please, Amita, you take over the session and introduce the chairperson.
Thank you, Ranjana ma'am. A very good evening and warm welcome from my side also to all the delegates and faculty. We are so very thankful that Amravati, Solapur, Yavatmal and Allahabad Society are with us today. And I can proudly say today is the 35th episode of our scientific Sangam. And as Sir William Osler has once said, that one who knows endometriosis knows gynecology. So today, starting with the first session, then endometriosis, recurrent adolescent endometriosis, will be covered by none other than founder president of ISOPARB Prayagraj, Dr. Ranjana Khanna ma'am. And we all know that she is standing for the post of President FOGSI. We'll talk about this later. And welcome, ma'am. And to chair the session, we have with us Dr. Rashmi Kahat. She is President Amravati Obs and Gynae Society. She has been organizing secretary of AMOX 2020. And she is joint secretary of Vidarbha ISOPARB. She has edited many books, contributed many chapters. She is recipient of many awards like...
Thank you so much.
Welcome, Dr. Rashmi. Welcome, Dr. Rashmi. And next chairperson is Dr. Sushma Tarak. She is Associate Professor OBGYN, Sri Vasantrao Nayak Government Medical College.
Thank you, ma'am, for nice introduction. Good evening, everybody. Thanks, ISOPARB Prayagraj, for including our society for this wonderful webinar on endometriosis. Today's topic for discussion is recurrent adolescent endometriosis. Endometriosis is a chronic condition that can significantly impact the lives of those affected, and while it is commonly associated with adult women, but it is crucial to recognize that it can also affect adolescents. Endometriosis can lead to a range of symptoms. For many young women, these symptoms can be debilitating and can interfere with daily activities, school performance, and overall quality of life. This condition is often misunderstood and is diagnosed particularly in adolescents and waiting years to receive appropriate treatment. This delay can have profound effect on their physical and emotional well-being. Today, we aim to increase the awareness about recurrent adolescent endometriosis. I request Dr. Ranjana Khanna to enlighten us regarding the recurrent endometriosis in adolescents. First of all, I request everyone to please vote for Madam. Madam is competing for President FOGSI election year 2024. Madam is the Vice President FOGSI 2017. She received many national awards as like Achievers Award, DeeReg Award, and FOGSI DK Tank Reproductive Health Promotion Trophy, and FOGSI Smriti Milan Award. She's now the Senior Consultant and Director at Ranjana Hospital in Prayagraj. Ma'am, over to you, ma'am.
Thank you so much. Thank you so much, Sushma, for the vote appeal, particularly because that is what is very important to me at the moment. So, good evening, friends. I am going to speak on a very pertinent subject nowadays, which is very, very important. That is recurrent endometriosis in adolescents. What next? So endometriosis, we know, is a riddle wrapped in mystery inside an enigma. Adolescent endometriosis is unique in a sense that a girl has to spend the major part of her life with immense suffering and decreased fertility prospects. The incidence is difficult to quantify, and around 47% of the girls who undergo laparoscopy for chronic pelvic pain have endometriosis. Earlier reports were that adolescent endometriosis was exclusively or mostly stage 1 and stage 2. But now it is seen that a much higher proportion of young girls have advanced endometriosis. A significant proportion of advanced disease, stage 3 or 4, is seen in adolescents, and all stages of endometriosis, including deep endometriosis, ovarian endometriomas, are all found in adolescents. And the condition is not limited to early forms only as initially thought. So why is the delay in diagnosis? Could be because of atypical symptoms or atypical endometriotic lesions. The atypical symptoms could be dysmenorrhea, which is resistant to non-steroidal anti-inflammatory drugs and or oral contraceptives, acyclical CPP, dyschezia, constipation, intestinal cramps, exercise pain and bladder pain. Sexually active teenagers report dyspareunia, and because of that, there's absenteeism from school also. Atypical endometriotic lesions, we have to be familiar with these lesions, and otherwise the diagnosis is likely to be missed. So sometimes it is red and sometimes the lesions are white in color. So these are the white lesions which are seen by the arrow. Atypical clear endometriosis lesions studding the peritoneum of the posterior cul-de-sac. And these are found in an 18-year-old patient with stage 1 endometriosis who also had a family history of the disease. Now, these are hemorrhagic endometriosis involving the left pelvic side wall, and there's an atypical white fibrotic lesion, the double arrow shows it, immediately over the left ureter and left ovarian fossa in a 16-year-old patient with stage 2 endometriosis. Then, of course, these are cortical endometriotic lesions in a 15-year-old patient with stage 3 endometriosis. This is scattered, variable appearing endometriosis lesions with severe disease in the left pelvis. The endometriosis invaded the retroperitoneal fibroadipose tissue of the left posterior cul-de-sac and also involved the left paraureteral region. And again, these are the hemorrhagic typical red endometriotic lesions involving the left broad ligament and the perivascular peritoneum in a 20-year-old patient with stage 2 endometriosis. So what are the major issues in the management? Early diagnosis and prompt treatment reduces the risk of future sequelae, including multiple laparoscopies in adulthood. Now, the main aim is to preserve the fertility along with improving the quality of life. So there is a lot of psychological and social impact of this of endometriosis on these girls. Endometriosis, we know, constitutes a disabling condition which particularly affects the social relationships as well as sexual and mental health. Several studies have highlighted the impact of chronic pelvic pain on the psychology of these girls. Notably, pelvic pain and infertility are commonly associated with psychic vulnerability and drug abuse. So what is the debate? Some people say that early medical treatment improves long-term outcomes. Others opine that this simply increases the number of interventions without preventing the disease progression. So what are the medical therapies? The details will be taken by Dr. Pushpa, but just to touch the subject, NSAIDs, COCPs, progestogens, Dynogest, LNG-IUS, GnRH agonist along with ADBAC therapy. NSAIDs are the first choice drugs for treatment of pelvic pain and dysmenorrhea, but a recent Cochrane review does not confirm its efficacy because of lack of high quality evidence. Now, when we talk about COCPs, cyclical COCPs can be used for longer periods. Estrogen and progesterone contraceptives are a good option in those patients who have slight pelvic problems and they don't want conception also at that time. So long-term continuous OCPs for symptoms of dysmenorrhea who did not respond to cyclical COCs, one pill OD for 6 to 9 months, so a sort of pseudo-pregnancy is created. Then vaginal contraceptive rings are there, patches are there, they are also effective. Progestogens, medroxyprogesterone acetate, 30 to 50 milligrams per day for 4 to 6 months. Then we have DMPA injections, which are given 3 monthly for 1 year. Then norethistron acetate, 5 to 15 milligrams daily for 6 to 9 months. Again, the concept is to maintain a sort of a pseudo-pregnancy period for the endometriotic lesions to subside. LNG-IUS, the advantage is it prevents recurrence and relieves the pain. Dynogest nowadays is the most commonly and the first line drug which is used. It has got a profound effect on the endometriotic lesion. It's got a good safety profile and a phase 2 safety study has been done and it's for its use in adolescents as well. Dynogest 2 milligrams OD for 52 weeks caused a decrease in the BMD of the lumbar spine and partial recovery only was there after stopping treatment. So it's recommended nowadays for 3 to 6 months, but can be used long-term and we can always give add-back therapy. LNG-IUS is a very acceptable option and there's less effect on BMD. It reduces recurrence, minimal changes in lipid profile, insertion could be difficult, but we have the low-dose LNG-IUS for these adolescent girls. Cabergoline is a dopamine agonist. It suppresses the cell proliferation and VEGF-mediated angiogenesis. It has got very few side effects, but then there were studies which compared in endometriosis the role of Dynogest versus cabergoline, and they found that the reduction of the lesions was better with Dynogest, but the reduction of the pain was better with cabergoline. The dose is 0.5 milligram bi-weekly to begin with, then weekly for 3 months. Then GnRH agonist along with add-back therapy. Now, what are the practical considerations for long-term medical therapy? Surgical confirmation of diagnosis is always preferred. However, many guidelines support treatment initiation with NSAIDs and hormonal treatment without laparoscopic diagnosis after appropriate counseling. To protect the ovarian reserve, there is an increasing trend towards medical management in asymptomatic patients. Laparoscopy is not indicated for diagnosis alone unless you want to do laparoscopy for diagnose and treat immediately. Combined approach of surgery followed by post-operative medical therapy offers the best long-term outcome. The treatment should be patient-centric and goal-oriented approach should be there. Coming to the surgical management, we all know that laparoscopy is the gold standard for diagnosing and treating. Implants can be destroyed via electrocautery, coagulation, ablation, or excision. The lysis of adhesion should also be performed. LNG-IUS can be placed at the time of laparoscopy. Appropriate timing of surgery for adolescent endometriosis is still debated. Some recommend that you should avoid surgery as far as possible because of high recurrence rates. Others suggest immediately do surgical intervention so that the disease doesn't progress further. Further research is needed to determine the best approach at the proper time for adolescent endometriosis. Now, we come to endometriomas. Some say that more radical, then more interventions have to be done and the ovarian reserve is impaired. Then others say that if it's less radical, then there are more chances of recurrence. So laparoscopic cystectomy for endometrioma should be undertaken if the endometrioma is more than 4 centimeters and it causes pain. That is level A RCOG recommendation. Avoid surgery if it is a painless endometrioma less than 4 centimeters, minimal to mild stage endometriosis, and we must always assess the AMH prior to surgery. That is mandatory. And avoid unnecessary surgery. That is the main bottom line. So each case has to be handled individually. Careful surgery by experienced hands. Please don't try to do unnecessary surgery and radical surgery, remove the ovarian follicles, destroy the patient's life forever. Please don't do that. Refer her to a very trained endometriosis surgeon who will preserve the fertility and cure the disease as well. Preventing injury to follicular reserve is very important, and preventing post-surgical additions. Choose the best surgical technique to avoid ovarian damage. Excessive stripping of ovarian cortex and use of bipolar coagulation to stop bleeding should be avoided. Bilateral cystectomy of endometrioma will result in reduced AMH. Now, what is the limitation of this management? We must remember that the treatment of endometriosis is suppressive rather than curative, contraceptive rather than fertility promoting. Endometrioma, there is lack of effective medical therapy, limited option for deep infiltrating endometriosis, and there is very little research at present. Risk factors of recurrence: bilateral pelvic involvement, previous surgery, tenderness or nodularity at the cul-de-sac, post-operative high RAFS, younger age, type of surgery, and pre- and post-operative medical therapy. So what is recurrent endometriosis? Spontaneous resolution can occur in about 20% of endometriosis stage 1 and 2. Residual disease is the persistence of symptoms or reappearance of symptoms within 3 months. But if it comes on after 3 months, it is recurrence. The incidence is 6 to 30% in various studies, depends on the age, the stage of disease, prior treatment, completeness of surgery, extent of peritoneal disease. Usually presents as chronic pelvic pain and dysmenorrhea. Now, how do we diagnose recurrent endometriosis? Diagnosis is by a rising CA-125, TVS, MRI, laparoscopy. Treatment is painkillers, hormones. Conservative surgery is indicated if medical therapy fails or contraindicated, or there are some side effects. Cystectomy, adhesiolysis may be an option after IVF fails. Post-operative hormone therapy delays recurrence, but does not reduce the recurrence. LNG-IUCD reduces recurrences post-surgery, and the role is being studied in recurrent disease. Ultimate treatment, hysterectomy with bilateral salpingo-oophorectomy. Catch them young and limit the recurrence. Now, if there was something that could tell us, if we could predict that this girl will move on to advanced disease and this girl will have a limited disease, then it would help us in treating the patient, and it would prevent us from performing unnecessary extensive surgery and unnecessary interventions. So, is there any difference in the origin of adolescent endometriosis as opposed to the adult endometriosis? Yes, it is said that the origin is different, and traces are there in the, when you have a child, a girl child who's born, and sometimes the neonates bleeds from the vagina. So these are the neonates actually who later on develop endometriosis. And there are genetic biomarkers which are there, blood-based biomarkers, immune markers, glycoprotein markers. All these markers are there. VEGF, we have CA-125, we've already talked about. Most of these endometriosis biomarker studies have remained at level of phase 1. Only few have made it to phase 2. So epidemiological risk factors, maternal and reproductive factors, early age in menarche, and short menstrual cycles. These girls are predisposed to endometriosis. Pregnancy, use of OCPs. COCs are not considered protective against endometriosis. This is a level C ESHRE guideline. Menarche at age 14 years or later, less likely to develop endometriosis. If there's a positive history, more likely for endometriosis. And of course, if there are obstructive type of Mullerian anomalies, because then there's regurgitation of the menstrual flow. In utero environment, they say that if there's maternal exposure to environmental toxins like cigarette smoking, women with low birth weight, maybe extra intake of alcohol or caffeine, that can also predispose to endometriosis in the child when she grows up. Then physical characteristics, they exactly don't know how these affect, but they do have some effect on the development of endometriosis in the adolescence. Then inverse association has been found between endometriosis and adult body mass index. So it has been seen that childhood BMI and endometriosis have some sort of a correlation, because the more the BMI, then the lesser the chances of endometriosis. So indoor exposure to passive smoking causes an increased incidence of endometriosis. And of course, if you work night shifts. So dietary factors also could be responsible. So what next? Egg donation and or cryopreservation if low ovarian reserve is there. Excision of the ovarian tissue and autografting. Vitrification, cryopreservation technique by using cryoprotectant by ultra-rapid cooling, more successful in terms of oocyte survival. Then in prepubescent girls, immature oocyte cryopreservation is the only method to preserve fertility. But if we use prophase 1 geminal vesicle, it increases the risk of zona pellucida hardening and chromosomal aneuploidies. Ovarian tissue cryopreservation, reimplantation of the cortical ovarian tissue in the pelvic cavity. And it causes low birth weight babies, but they have normal growth rate after birth. So what are the newer treatments? Angiogenesis inhibitors, antioxidants, TNF. Then we have matrix metalloproteinase inhibitors, immunomodulators, Chinese methods, green tea, stem cell therapy, and of course, gene therapy. Pentaphospholene can also be used. VEGF-C has been suggested and ETA has also been used. So clinicians can use oxidized regenerated cellulose during operative laparoscopy for endometriosis because it prevents addition formation. This is level B ESHRE guideline. During laparoscopy in young women under GA, it is pertinent to introduce Mirena in the uterus to prevent the risk of recurrence. Although many women with endometriosis do conceive naturally and easily, women with endometriosis are more likely to have difficulty in conceiving. This is mainly because of the effect of inflammation in the pelvis, which can cause metabolic stress for the ova in this environment. Surgery for endometriomas can also reduce the ovarian reserve. Egg freezing technology has improved, and it is possible for young women with endometriosis to freeze the ova so that they can use them to conceive later on in life. Our duty as gynecologists is to provide more information about preserving fertility. Thank you. And before I say actual thank you, I am standing for the post of President FOGSI, which is a very prestigious post. I have worked tremendously for women's health. I have occupied several posts in FOGSI, like Vice President, and I have been president of my own society for 4 years. I have worked a lot, believe me, and very sincerely at that. My Allahabad society members can vouch for that. And I want to do a lot more for women's health with everyone inclusive, so that I believe that together we can, and together we will do a lot of work. So please, please, please do give me your vote and support. Thank you so much.
Thank you so much, dearest Ranjana Madam, for such a wonderful talk. And you really help us solve the various mysteries of this enigmatic adolescent endometriosis. As you very rightly said, in adolescents, diagnosis of endometriosis itself is a challenge, and we really need a very high index of suspicion for the same. And the medical management commonly used in adolescents, like the progestin therapies or the GnRH in rare cases, which will be a long-term therapy, will pose us with problems of bone marrow density decreasing. And so even we use this therapy, we will be in need of airbag therapy, as you very rightly said, supplementation of vitamin D in these adolescent girls, because their bone marrow density is will be a matter of concern for all of us. And what is important is the counseling of the girl with her family and giving an idea that there might be a decrease in the fertility in future, and act accordingly will be a great step. So thank you so much, madam. It was very wonderful. It was splendid, and it was a nice thing to listen to you. Thank you very much.
Thank you so much. Thank you so much.
And madam, we all wish you a very best for your FOGSI election, and all the best for your future endeavors.
Thank you so much, Rashmi. Thanks a lot, dear.
Thank you, Ranjana ma'am and chairpersons, for this wonderful session. The talk was, as usual, very crisp and clear with good take-home messages. As you have told in your first slide, this endometriosis is a riddle and enigma. And to treat this, there newer and newer drugs are coming in our way. And so our next session is about endometriosis and newer drug. And it will be taken, it is an honor that Dr. Pushpa Jangare ma'am, Professor and Head of Department, PDMMC Amravati, will be going to take this session. Please, and to chair the session, we have with us Dr. Charutha Ranade and Dr. Amrita. Dr. Charutha is President of Yavatmal Obstetrics and Gynecological Society, consultant obstetrics and gynecology, and she has been practicing for since last 19 years. Our next chairperson is Dr. Amrita Kumtekar. She is practicing as consultant OBGYN at Kumtekar Multi-Specialty Hospital, Solapur. She has passed MRCOG Part 3 examination in 2023 in the first attempt. She has a gold medal in FCPS examination. She has been assistant professor at KEM Hospital, Mumbai for 2 years. She has co-authored many articles in National Journal and worked as clinical secretary for Solapur OBGYN Society in 2020-21. Okay, may I request Dr. Charutha to please introduce our speaker?
Good evening, everyone. Dr. Pushpa Jungare, madam. She's MD, FICOG, FIC, MCH, professor and HOD, OBGYN, PDMC, Amravati. She's a member, UG and PG Board of Studies of Surgery and Allied Subjects, MUHS, faculty in many national, state and zonal conferences, CMEs and workshops, UG and PG examiner at various universities in India, past president Amravati OBGYN Society, organizing secretary State Conference of AMOGS in 2005, organizing chairperson for AMOGS 2020 at Amravati. She has won many awards and achievements in her credit. She is a popularized NDVH in Amravati region, instrumental in establishing first human milk bank in central India at PDMMC Amravati.
Good evening. At the outset, I would like to thank Dr. Ranjana, Khanna madam, and also would like to wish her all the very best for her upcoming elections. And I assure that we have full support from our society, that is Amravati OBGYN Society.
Thank you so much. Thank you so much, ma'am.
So, madam has already introduced something regarding endometriosis. I'll be just continuing with that, with the addition of newer drugs. By definition, all of us know it is presence of endometrial-like tissue outside the uterus, and prevalence is quite high nowadays, especially with increase in the better living standard. It is increasing. It has rose up to 10% of women of reproductive age group, and as high as 25 to 50% for women with infertility. Some of the patients may be asymptomatic, but most patients usually present with one or more of the associated symptoms, including dysmenorrhea, chronic pelvic pain, deep dyspareunia, cyclical intestinal complaints, fatigue, weariness, and infertility. And they progressively impair the quality of life of the woman so that she is unable to carry out her certain daily activities, and it affects her health status and overall well-being. Moreover, women who are sexually active may have sexual dysfunction caused by this disease. And it is associated naturally with direct and indirect cause because she might lose her working days. And that is going to definitely affect her economically. And finally, endometriosis-related symptoms substantially interfere with the employment of the affected women, often resulting several missed work days. Pathogenesis, it is controversial, so I won't dwell more upon it. Coming to the treatment of endometriosis, symptomatic endometriosis remains the prime indication for the treatment. Ideally, treatment should provide pain relief and allow pregnancy to occur safely when she is undergoing treatment. That is, the treatment should not affect her fertility. The current treatments for endometriosis, it includes surgery, ablation using either laser or electrosurgery if laparoscopy is performed, pharmacological therapy, or a combination of both. The choice of drug therapy should essentially offer relief from her symptoms without inhibiting her ovulation, causing amenorrhea or adverse effects. And the goal of drug therapy for endometriosis is to relieve pain. That is the main symptom of this patient. They are very much worried, that is, they lose some productive days in their life because of this severe pain. And definitely it should improve her fertility if she is interested in childbearing. Studies showed that long-term drug management, even after surgery, that is post-surgical operation, it delays the recurrence of endometriosis symptoms among these patients. The basis of medical treatment is to prevent the stimulation of endometrial tissue by the suppression of estrogen secretion or antagonizing the estrogen action. This is achieved by the drugs that suppress the ovarian steroids and induce hypoestrogenic state that causes atrophy of the ectopic endometrium. At present, the drugs most commonly used to treat endometriosis includes NSAIDs, as Khanna madam has already elaborated, progestogens, combined oral contraceptives, GnRH agonists as well as antagonists, selective progesterone receptor modulators, selective estrogen receptor modulators, and aromatase inhibitors. There are some new products such as prostaglandin E2 receptor antagonist, reversetrol, IL-1 antagonist, and dopamine receptor antagonist. The most commonly used drugs, progestogens, these drugs, they exhibit therapeutic effects on endometriosis through multiple mechanisms, including modulating estrogen receptors, inhibiting inflammatory responses, preventing endometrial proliferation, and promoting the apoptosis of the endometriotic cells. Progesterone also reduces oxidative stress by reducing or eliminating uterine bleeding in endometriosis lesions. In addition, these drugs also stimulate the atrophy or regression of endometrial lesions, inhibit angiogenesis, and reduce the expression of matrix metalloproteinases, thereby reducing the invasive ability of the endometriotic implants. And finally, these progestogens, they reduce the frequency and amount of pulsatile gonadotropin releasing hormones, the release of these hormones. This leads to decrease in FSH and LH secretion, thereby establishing a low estrogen environment that inhibits endometriosis and prevents progression of the disease. Dynogest, this is the not actually new, but out of the many, it is comparatively new and it is still very much in vogue to use Dynogest. It is a newly marketed 4th generation selective progesterone that combines the pharmacological properties bis-methyl-testosterone and progesterone derivatives. The characteristics of 9 bis-methyl-testosterone derivatives make Dynogest highly selective to endometrial progesterone receptors and exhibit an efficient progesterone-like effect. Its pharmacokinetics, it has that advantage of short half-life, good bioavailability, and no accumulation under in vivo condition. The characteristics of progesterone derivatives make DNG exhibits good tolerance in patients, anti-androgen effect, moderate inhibition of hypothalamus pituitary ovarian axis, moderate reduction of estrogen level, and with limited effects on the metabolism of estrogen, glucose, salt, and lipid in patients. It also exhibits strong anti-androgen activity with zero action on glucocorticoids or halocorticosteroid-like effects. What's more, it does not activate either estrogen receptor alpha or beta. Under in vivo conditions, DNG exhibits critical pregnancy-like effects. It inhibits the release of gonadotropin, but does not exhibit glucocorticoids, mineralocorticoids, or significant estrogen-like effects. Most of the side effects occur in the first few months of the treatment, mainly include abnormal uterine bleeding, headache, constipation, nausea, fever, and weight gain. There might be breast discomfort, rarely personality changes, and libido loss in some women. In conclusion, DNG is the only oral progesterone drug specifically designed for the endometriosis treatment. It is effective in alleviating pain symptoms associated with endometriosis, such as dysmenorrhea, premenstrual pelvic pain, difficulty with intercourse, that is dyspareunia, and chronic pelvic pain. These are the most disheartening symptoms of the patients of endometriosis. It is mainly given to patients with mild endometriotic symptoms, but however, it shows poor therapeutic effects in patients with severe symptoms. And most of this, then they are going to need some surgical intervention. Moreover, the DNG dosing cycle is also long, usually 6 months of continuous medication, and it is not suitable for infertile patients due to ovulation inhibition. Therefore, there is still some scope for further optimization of Dynogest for the endometriosis treatment. If it is combined with ethinyl estradiol, there are many advantages. That is, apart from all the benefits of Dynogest, ethinyl estradiol provides endometrial stability, thereby minimizing the likelihood of breakthrough bleeding. And presence of estrogen potentiates the action of progesterone. That is another advantage. And of course, the combination drug is cheaper than Dynogest alone. For example, free days, the complete course of 3 days, which is to be taken for 28 days, it is going to cost almost 1/3 of Dynogest taken alone for the whole month. So it is almost 1/3 the total cost of Dynogest alone. Coming to gonadotropin releasing hormone agonist. This binds to most of the gonadotropin releasing hormone in pituitary. Therefore, reduces the binding of endogenous GnRH to GnRH-R. And this results in decrease in pituitary gonadotropin secretion, reduces the level of steroid hormones, and induce low estrogen status. As this drug can cause osteoporosis and hypoestrogenism, some hormones should be supplemented to prevent loss of bone and hypoestrogenic symptoms during treatment. The examples of these drugs are gonarelin, goserelin acetate, and lupride depot injection. Coming to gonadotropin releasing antagonist. They competitively bind to the GnRH on the pituitary, blocks the endogenous GnRH, binds to GnRH releasing factor, further reduces the secretion of endogenous gonadotropin in few hours after medication without flare-up effect. And besides this, GnRH antagonist, it has got a short dosing period, so it does not cause a decrease in pituitary reactivity after discontinuing its use. Examples are elagolix and relugolix. There is a combination, the latest, you can say, the regime, known by name RICO. It is a combination of relugolix, estradiol, and norethistral. So it puts in all the good points of GnRH antagonist, estrogen, and progesterone. It is a tablet containing 3 different active ingredients. So it is a drug that blocks a particular peptide from releasing other hormones. Estradiol is naturally occurring estrogen hormone, and norethisterone is a synthetic hormone. It reduces the overall levels of estrogen and progesterone in the body. It is GnRH antagonist. The estradiol compensates for the loss of estrogen because low estrogen levels can cause hot flushes and bone density loss. So that can be compensated because of this addition of estrogen. Norethisterone blocks the effects of estradiol on the uterus and prevents endometrial hyperplasia. So one drug balances or you can say counteracts the ill effects of the other drug. All 3 components, they work together to regulate the levels of estrogen, progesterone in the body that contribute to endometriosis, alleviating its symptoms. So this is a very good drug recently introduced, and there is a good scope for its use. Coming to dihydrogesterone, this dihydroretroprogesterone is a retroprogesterone derived from progesterone that is similar in structure and pharmacology to endogenous progesterone. It acts as a selective progesterone receptor agonist. Dihydrogesterone is used for treatment of endometriosis. That is, apart from many other uses, it is being now used for endometriosis. In fact, for many years, but it has been promoted recently with a sustained release tablet of 30 milligram daily. It can be given cyclically with a break, or it can be given continuously. It is shown that dihydrogesterone relieves the symptom of endometriosis, regresses the lesions, and improves pregnancy rates in patients with infertility. So it does not suppress the ovulation, and it is useful in patients with infertility. The proposed mechanism underlying the pharmacological action is the progesterone. It involves the initial desudalization of endometrium and eventual atrophy. It causes atrophy of ectopic endometrium without suppressing the normal endometrium, and simultaneously inhibits the development of new endometriotic lesions. Furthermore, it does not inhibit ovulation and regular menstruation, and does not induce weight gain and edema. So all the ill effects of the previous drugs, dinogestrone, they are overcome in this dihydrogesterone therapy. So as I've told you, it is given as sustained release tablet, 30 milligrams daily or cyclically. Coming to letrozole, this is a third generation aromatase inhibitor. It is highly potent, having specific suppressors of estrogen production locally and as well as systemically. It prevents the secretion of estrogen and prevents the activation of endometriotic implants. Combination of letrozole 2.5 milligrams, norethindrone acetate 2.5 milligrams daily for 6 months reduces the size of endometriotic lesions. Preferably calcium and vitamin D should be added to this therapy to prevent the complications of hypoestrogenism. So whatever drugs we are using, which are acting as anti-estrogen drugs, in those definitely there should be backup with calcium and vitamin D. And we should provide something as a backup to prevent hypoestrogenism problems. Other drugs that are used, medroxyprogesterone acetate either orally or parenterally, 150 milligrams intramuscular every 3 months or 100 milligrams per day for 3 to 6 months. Norethindrone acetate, combined OC pills, these are being conventionally used, and conventionally used because they are much, much cheaper than dinogestrol or even combination of dinogestrol and ethinyl estradiol. LNG intrauterine, about this Khanna madam has already elaborated, and they are available with low doses, especially when they are needed in younger women. They are available with lower doses. And then other drugs are also available, like anti-angiogenesis drugs like cabergoline. So these are newer drugs. The evidence-based studies, they are not sufficient to routinely prescribe these drugs, but definitely there is a role of dinogestrol alone or combination of dinogestrol and ethinyl estradiol. So we can do away with surgery if the patients are properly treated with the rational use of this newer drugs. So we can either postpone surgery, or even after surgery, if they are given, definitely they are going to reduce the recurrence of endometriosis, which is definitely as long as the ovaries are active, this endometriosis likely to recur in majority of these patients. So finally, when they reach the age to have hysterectomy or do away with the uterus and the ovaries, till that time, the treatment with medication or oral drugs, that is very much necessary. For drugs is definitely.
Ma'am, is this drug RICO available in India?
I have inquired. So far, at least in our city, it is not available. I don't know about metropolitan cities like Mumbai or.
And Dr. Manju Varma, ma'am, any inputs? You want to say something?
Well, I would like to simply congratulate the speakers
for enlightening us about so many new things which are now coming. Now, of course, for a little time, they have been into practice. My only thing now is that I will request everyone to support, vote for Ranjana. Thank
She
you. I
deserves
would
to be our next
just
president.
want you to be to vote and vote for Ranjana and support us other people also do it for her.
Thank you, ma'am. Thank you, Dr. Pushpa, ma'am, and chairpersons for this very informative session. And thank you, ma'am, for this vote.
Ma'am, Dr. Pushpa, ma'am, you're not using cabergoline for
not very frequently.
And what is your opinion? You prefer Dynogest or you prefer this combination?
Because of the cost factor, I have started using this combination of ethinyl estradiol and Dynogest, because Dynogest dose remains the same.
Yeah.
The cost is
Dynogest,
reduced.
the dose is the same. But I remember
Yes.
I was hearing a talk that was I think a year or so back by Dr. Pratap Kumar, and he was against this combination. He was saying that Dynogest is better than this combination. Dr. Manju Varma, ma'am, what would you like?
Ranjana, I would like to say that with Dynogest, there are chances of menstrual problems, right?
Menstrual
So
irregularities are very much there.
Yes.
But
And that is
Dr.
just
Pushpa, ma'am, what do? You give it continuous, like we were talking about, you were talking about 3 days. So you give it in continuation or cyclical?
No, I prefer it to give cyclical.
Cyclical, na?
Patients, actually, they are not very happy when they are amenorrheic.
Exactly.
There is some psych.
And then sometimes
we want that patient should be...
sometimes even if you are giving them this combination, then there is slight breakthrough at the time of periods.
Yeah.
I have observed some breakthrough.
Ranjana, may I speak something?
Hanji.
Yes, sure, ma'am.
Sabko mera namaste. I have got my own views. May I tell it?
Hanji, please do.
After, say, more than 44 of experience in practicing and more than 30 years experience on endometriosis, I will not like to have any break, if not required for fertility purpose, in giving treatment for endometriosis. I don't want any bleed inside or outside the uterus, because once the bleed is there, all the interleukins, all the TNF alpha, all the VEGF will be stimulated, and it is our defeat. We should not go for any defeat, even for adolescent girls also, because once the bleed is there, our purpose is just not there. Regarding the combination therapy of the medical treatment, yes, I go for it. And because there are 4 phenotypes of endometriosis. One is peripheral, the other is endometrioma, the third is DIA, and the fourth is adenomyosis. And they coexist even along with the fibroid also. So whenever we are giving our treatment, we have to find out by not laparoscopy, but by a good digital ultrasound after good bowel preparation with TVS, with high power Doppler flow, to understand where the disease is and how to go for it, in which age group, and what is her demand for fertility. So having these concepts in mind, I go for the Dynogest only when fertility is not required, I'm telling you. Because giving too much of Dynogest causes fibrosis. As we know, there's an adhesion, there's a proliferation, then there is a fibrosis and invasion along with it. So fibrosis is not good at all for pregnancy. We want to dissolve the condition. And for this, nowadays, I give a combination of VEGF anti-drugs, like mentioned already by Dr. Pushpa. That is cabergoline is one of them, and I like it very much. Dr. Ranjana has already mentioned, I give it 0.5 milligram bi-weekly for minimum 12 weeks, and then for the 3 months, we can give it like weekly for 12 weeks. So 6-month therapy we can give. And regarding progesterone therapy, yes, I add according to the phenotype. That is by giving like sustained registrone, you can give 10 or 15, depending on her spotting bleeding in between. because that too works. I told you many phenotype, many etiopathogenesis also of this disease. So one is controlling, other is not controlling. And the third drug we are mentioning about the letrozole, that I don't usually use for combination, but of course, when it is not responding much, then when I use this letrozole 2.5 milligram or anastrozole 1 milligram, that is we give in a post triple negative breast cancer. As a supplement, we give not to progress the disease. Here we give not to have VEGF and not to have progression of this estrogen dependent disease. So this is also good. And here I give the combination of cabergoline. Both will work, but giving this progestogen, I don't use in it. And regarding the third combination, we are just discussing relagolix along with norsyndrone. 2.5 is not very bad. I have not used it, but we can supplement. And this is very costly drugs, elagolix, relagolix, and their dose is also very different. We cannot give it continuously, and we can have a 7 days therapy in a month or like that. So they have got different way of mode of action. So Dr. Milind Shah has just joined, and I will like to have his views also regarding relugos and their continuous therapy, which dose, which drug. So
But
this is
Anuradha ji, when you are giving Dynogest and estradiol combination, and if there is
I
breakthrough,
usually don't give.
the
I don't
combination.
give it for endometriosis. No, I never give.
Actually, the
and
basic principle which we were taught was that Anuradha, you must be thinking you have to create a condition of
Pseudo-pregnancy.
either pseudo pregnancy or pseudo. So if you give
Pseudo-pregnancy has to be
small,
created.
actually, because of the breakthrough bleeding, it was added, and there are studies which are now coming up to in support as well as negating, right? So
the dose of estrogen, I'm concerned. It is not that I'm not giving it. I like a drug
well, a
with
small
20
We
milligram of
used to give in
estradiol,
our
not
times,
30.
in
Not
our times, we used to give 15 milligrams of norethistron acetate over a period of 6 to 9 months. Pseudo-pregnancy was created, and that used to relieve the symptoms of endometriosis. But that was way back.
No, still you are getting the 15 CR sustained release. You are
Can I
getting
add
15.
one point on this?
Sure, Milind.
Yeah, though we are going to have a elaborate discussion on this when the question came about this combination of ethinyl estradiol and dynogest. Yes, there's a very limited indication, but there is, which I practice in my own clinical actually setup. Those cases with mild to moderate adenomyosis presenting with pain, spasmodic dysmenorrhea.
Yes.
To reduce the cost, sometimes we give this combination of 3 months and we found wonderful results. But yes, Dr. Anuradha, you're very correct. It doesn't have much actually the scope per se.
But you are giving it cyclically, or are you giving it continuously?
No, we give it cyclically 3 months and it really works. Otherwise, the first choice is always giving continuous dynogest for 6 months. But quite few of our patients are not affording. So they, they are a little hesitant to spend that much of money over the period of 6 months. So only cases of mild to moderate adenomyosis with substantial pain during menses or premenstrual pain, they give wonderful with cyclical months. So requesting you all to give your inputs as well so that we can have the experience over time.
Yes.
Yeah.
So thank you
Yes,
everyone
Amita.
for
Because as I said in the beginning, that endometriosis is an enigma. And everybody has their own way of treating it actually, because still we are clueless about several things in endometriosis. Why
many
it progresses, why it does not progress in some, why it regresses itself. We don't know why it happens.
It's a disease
to some
of
extent,
dilemmas.
Dr. Ranjana, as I said, this has got different etiopathogenesis, different phenotypes. So it's very simple. We have to understand where the disease is and what will be the best. And that is our progressive nature of learning.
Yes.
Our learning.
So thank you, Dr. Pushpa. It was a lovely talk and a very complete presentation so that we could all get a bird's eye view of everything.
So thank you everyone for this very informative session. With this, I hand over the session to communicator of ISOPARB Prayagraj, Dr. Parul Khanna, to handle the next session, the panel, infertility and endometriosis. Over to you, Dr. Parul.
Thank you, ma'am. So I welcome you all to this webinar. Now we move on to our third session, which is a panel on endometriosis in infertility. And moderator for the panel is Professor Dr. Milind R. Shah. Sir is President ISOPARB from 2016 to 2018. He has been member of Maternal and Fetal Medicine Committee of FOGSI, President of Indian Medical Association Solapur branch, Chairman of Safe Motherhood Subcommittee, IMA Maharashtra, Founder President of Infertility and High Risk Foundation, Honorary Secretary General, Federation of Asia Oceania Perinatal Societies, Vice President of FOGSI 2011, President-elect ISPAT 2019-21, Deputy Secretary General INSARG, Indian Society of Aesthetic and Regenerative Gynecologist. He has been ex-chairman of Rural Ops Committee of FOGSI, ex-committee member of various societies like IAG, ISAR, peer reviewer of Journal of OBGY, past steering committee member of Asia Safe Abortion Partnership, professor in HOD, Department of OBGY, Gandhi Natha H Medical College, and he has delivered various lectures in OBGY nationally and internationally. I welcome you, sir.
Yeah.
Our expert for the panel is Professor Dr. Anuradha Khanna, ma'am. CV, please.
Please put the CV of Dr. Anuradha, ma'am.
Ma'am has been ex-HOD, OBGY, Banaras Hindu University, Varanasi, ex-president of VOGS, president SFM UP chapter, president of Varanasi Menopause Society, president of UPCOG 2022-2023, organizing secretary of UPCOG, AICOG, scientific chairperson.
Parul, theek hai. It's okay.
I welcome you, ma'am. Now I invite the panelists for the panel. Our first panelist is Dr. Rajni S. Kamble. She is a practicing obstetrician and gynecologist at Samayak Orthopedic and Maternity Hospital, Yavatmal. And she has also been past president of Yavatmal Obs and Gynae Society. She has also been recipient of FOGSI President Rotatory Trophy and Dr. D.K. Dang Trophy, Dr. Sadhna Desai Population Stabilizing Trophy. I welcome you, Dr. Rajni. Our next panelist is Dr. Monali Sukesh Dhole. She's a practicing obstetric and gynecologist and laparoscopic surgeon and an infertility specialist at Dhule Hospital, Amravati. She is also founder president of Rotatory Ambika and secretary of Amravati Obs and Gynae Society. Our next panelist is Dr. Vijay Pawar. He is consultant SIMS Fertility Center, Solapur, associate professor VGMC, Solapur and unit in charge, ex-clinical associate regenesis, Center for ART, Endoscopy and Fetal Medicine, and he has also fellowship in ART and minimal access surgery. Our next panelist, Dr. Gupte. She's head of Gupte Hospital Private Limited, Solapur, senior infertility and IVF specialist at Apollo Fertility, with 12 years of experience in IVF and laparoscopy. I welcome you, Dr. Meenal. Our next panelist is Dr. Anjali Gallan. She is center head in the IVF Allahabad, and she has also delivered first PGS baby of Allahabad. She has been awarded Best IVF Specialist by AMA 2023. Our next panelist is Dr. Sueba F. Hussain. She is senior consultant in IVF.
She's not there. She's not there.
So I have simply start the panel. Our next panelist is Dr. Saurabh Bhargav. He is an obstetrician and gynecologist and has fellowship in minimal access surgery and fellowship in MISII from Kochi. He is director and chairman, Vinayak Hospital, Jaipur. So I welcome all the panelists and I hand over the session to Dr. Milind.
Yeah, very much Parul for this, my wonderful panelists who are so expert in their own fields. It's really going to put a lot of light on this enigma which Ranjana thought about. It's really a great vision, Ranjana. You have very sure this vision is going to go a long way for country as well in coming years. And when you have a very supportive hands like Amita, you know, the way she was communicating with all of us, I really feel that now next year I should bring her to Solapur to stay with me for 1 year. Of course, of course, pleasure to meet Dr. Uma Jaiswal as well. When I had come recently to Allahabad, always enjoyed actually working with her for that cosmetic gynecology. And when I saw Dr. Anuradha as an expert, I said my half work is done. So she's going to definitely put all her inputs as she already started doing so. So that is going to go a long way. When I saw that all these societies of Yavatmal, my own society, Solapur, Amravati, Allahabad are coming together, I immediately said yes, because this was a wonderful opportunity for me as well to meet all my friends from Yavatmal. I had a very golden memories of Yavatmal as well, because you know, my daughter was there for 1 year, and during that period, the love and affection I have received from Rajani and Sushma and all other people, actually the Charula, everyone was so actually supportive and accommodative. I always remain for that. And now when Bella got her baby, I still became more emotional to meet all of you, and I'm very sure my own society. What should I say about it? Vijay, Minal, all are the very young and enthusiastic people, and they are doing wonderful work under the leadership of Dr. Neeta Ghate, Dr. Amrita Kumtekar. And I'm very sure all this is going to go a long way. When we received this a lot of blessings from Dr. Sanjay Gupte and Dr. Suvarna Khadilkar, I could not see actually Sandeep, but I'm very sure he must be there in the field as well. With this, we are going to add some more light on this endometriosis enigma, and commonly seen is the infertility for which the people present. And when we have all these people with us who are going to put some inputs on the various aspects, I'm going to have a very brief, actually, the concept about this endometriosis and infertility, and then going to put certain cases whereby I will receive actually the inputs from you all. And when we have a very eminent endoscopist like Saurabh, I can see him either here. That there will be a lot of discussion on the surgery as well as the medical management of endometriosis. So let me share the slide, please. Yeah, it's there. Yes.
Dr. Milind, in between,
Yes.
I will have an announcement that
Yeah, sure.
our Varanasi Society, along with Endometriosis Society of India, we are going to host a conference on 21st and 22nd of December. This is whole lot on endometriosis only. This will be the first major conference in Varanasi, and I will share the details in the group.
Definitely, we'll be happy to looking forward to see it. Yeah, yes, yes.
That's why I mentioned.
Great, great. Yeah. So let me once again thank my all Allahabadi friends for inviting me, especially Ranjana and Amita and all others for this very important, actually, the discussion on the infertility and endometriosis. Let me see whether my slides are moving. Yeah. Can you see my slides moving on the screen?
Yes.
You are. Okay, great, great. So friends, it's very aptly said by Ludwig. The problems are solved not by giving new information, but by arranging what we have known since long. Because you know that whenever we say about endometriosis or any conditions in the infertility or the reproductive endocrinology, this person always and always gives us a lot of, you know, the knowledge, actually gave knowledge to all of us. I'm very sure all of you must have recognized him. Can anyone identify who is in the picture? Yes. Anyone from the panelist?
सर आप खुद हो ना बीच में?
Yeah, hello.
You are in the middle.
Yeah, I'm in the middle, but I'm asking about the legendary who is there in the field of obstetric gynec.
Dr.
Yes.
Spirov, sir.
Yes, very true. Professor Spirov, who always gave us a lot of input actually as far as the reproductive endocrinology is concerned. I still remember in those days the endometriosis diagnosis was not that easy because endoscopy was not very common. But still we had so many inputs on the various diseases in the women's body, especially related to the endocrinology and including the endometriosis that gave us input to date as well. We also understood that in our country as well there is lot of increased prevalence of endometriosis because our understanding about the disease is increasing, and that's why I'm very happy to tell you all that the ICMR is also conducting this particular study to understand the clinical phenotypes and genetic regulations for the endometriosis in Indian women, because we want to know what the things are, where the things are going wrong. And fortunately, I'm so happy and privileged to be a part of this particular study with ICMR, whereby we are understanding all those phenotypic features, how they are related to endometriosis. We are going to identify various genes in those women, and in coming days I'm very sure I'm going to come out with a wonderful result as well, how actually these genes are related to the endometriosis presentation in a given case. Now, we always used to link endometriosis with infertility for the obvious reason that that was the main concern for which actually the patients they used to come. We used to put the laparoscope and we used to find that yes, there is actually the endometriosis in that infertile women. But as our understanding increased, we have realized that it's not only the infertile. Many of the laparoscopic sterilization cases also we find endometriosis, and now teenagers having endometriosis is also very commonly seen. And the presentation, though infertility stands for quite few of them, they present with dysmenorrhea, chronic pelvic pain, and dyspareunia. When I was listening to these wonderful talks by Ranjana as well as Dr. Pushpa about this, various drugs, various treatment modalities, and various combinations which can be used, we need to think about these other indications also very seriously because those are the very commonly seen scenarios. I still remember a patient had come from Surat and who had come to us for the infertility when this particular patient was having the pain as well associated with her actually symptoms. We decided to put her for laparoscopy, and when we did actually the laparoscopy with corrective actually the ablations of endometriosis, patient said, doctor, first time in last 3 years I slept quietly without any pain. And then I realized, yes, it is not only the subfertility but also the pain which is there, especially in the advanced cases of endometriosis. But yes, these women are subfertile. That's very true. So let me put this particular question to all my expert panelists about this subfertility, why it is there in the cases of endometriosis. So anyone can take any questions, you can repeat, you can discuss, you can have the controversies as well, because that is what the main concern is whenever we discuss anything under panel discussion. And to top up, yes, Anuradha will be there to put more actually light on that as well. So anyone take this particular question, why there is subfertility in the endometriosis?
What I feel, sir, in the
Yes,
endometriosis, there are multiple reasons for the subfertility. It is not only the quality of oocyte, but it is the anatomical distortion, it is the adhesions, the quality of the oocytes, and it is a milieu in the endometrium, fallopian tubes, and ovaries, plus the peritoneal factors. All those work together to give you a subfertility.
Very true. So basically, this tubo-ovarian relationship itself get disturbed, and the adhesions in the scar, which causes these internal organs to get stuck to each other, and all this physiology, what we think about infertility, of grasping those actually oocytes who are coming eagerly to get fertilized, gets hampered. The tubal movement, the physiology, which is more important for any case of fertility, that is again gets hampered in the endometriosis, and that's why one need to definitely think about the various actually treatment options for the endometriosis and infertility. So here we deal with not only arranging that pelvic anatomy, but also taking care of dyspareunia, which could be another reason behind that unsuccessful implantation, altered peritoneal function, hormonal and ovulatory abnormalities, impaired implantation, and yes, as you said very correctly, the quality of oocytes and embryo. To again my surprise, I was just going through this book of Spirov when I was preparing this particular panel, and I realized that Spirov in those days also said these oocytes of PCOS, oocytes when the women have endometriosis, have a reduced fertility potential. And I was surprised. I said, oh my God, that time the technology was not that advanced, but still people were thinking about it. And of course, this uterotubal transport is again very, very important. Now, quite often we see that unexplained infertility, we put the laparoscope during our evaluation. So Vijay, let me ask you, do you find in your practice any times these patients they have, otherwise in the primary evaluation everything is good, when you put the scope and you find a mild endometriosis, and then what your perspective about that particular finding? You're not audible, Vijay.
Yeah, when the patients of endometriosis present to us, they can present with different ways. They can present as infertility, or they can present with dyspareunia or related to pain. So if you find unexplained infertility where you are not finding any cause, and when you put a scope, around 30 to 50% of your patients can have endometriosis, which can be mild and moderate. And as the panelist has already suggested, that may be the cause of their infertility. So laparoscopy plays a very important role, because sometimes this endometriosis can cause luteal phase defects. It can cause unruptured LUF, that is luteinized unruptured follicles. So your ultrasound plays a very important role when you're doing these evaluations. Nowadays, with the advances in ultrasound, we all have to get trained for this special endometriosis screening during ultrasound. So if we can find out these causes, so many of these unexplained infertility will be labeled as because of endometriosis. So laparoscopy definitely plays a very important role for diagnosis of endometriosis and treatment according to the findings. Yes, sir.
Yeah, correct, Vijay. When you said about this role of ultrasound, which is again very important, but let me ask the panelist about the role of other modalities as well. Do you find that there is some other modality which can put little more light on diagnosis of endometriosis by our imaging? Minal, are you there? Can I ask this question to you? Yes, anyone else can take. Saurabh, do you want to answer this?
Sir, I would like to answer. Dr. Anjali.
Yeah, please. Yes, Anjali,
Yes.
please. Yeah.
Sir, MRI can also play an important role
Yes.
in diagnosing
Yes.
endometriosis, especially the deeply infiltrative lesions, those who are affecting the bowel and the bladder. And so MRI plays an important role.
Very
Even
true.
if ultrasound findings are normal and patient has symptoms, then she can undergo an MRI evaluation.
Yes. And nowadays, every day we are getting new signs on the imaging, and that's why our understanding about the diagnosis of endometriosis on imaging modality is increasing a lot. And MRI is definitely a very important tool. But of course, the radiologist who's going to read that MRI is again very, very important. And whereby I find there is limitations at many places. I'm very sure it must be the same there as well. Now, suppose you
I want to
find there
say
is a
something.
mild and yes,
Rajni.
yes, please, Rajani, yeah, please.
Hello, sir.
Yes,
So
hi.
I just want to add something. Like I had one
Yes.
case of unexplained infertility, and
Mhm.
previous sonographies, USGs were done by radiologists only. And this time I said that I'll do your antral follicle count and all. So I was just I was inserting the TV probe, and she had pain. And she was not a diagnosed case of endometriosis, but what I found was she was pain, and maybe it is a really cul-de-sac pain. And I started her diagnosis, and she conceived after 4 months. So it is
Great.
also
what we are doing and we are assessing, it should be done by, I think, for obstetrician only.
Yeah, true. Very true, Rajani. As you said very correctly, these are the very important clinical findings. Again, very important. It reminds me of Dr. B.B. Kulkarni, with whom I used to work immediately after my post-graduation. And he always used to elicit those particular things, like, as you said, the tenderness, the contraction. He used to say, this particular patient may be having the endometriosis or tuberculosis in some cases. And it may always used to turn true, and but that gave us a third eye to diagnose these particular conditions as well. So Saurabh, I want to ask you, suppose you find there's a mild endometriosis. So are you going to immediately act on that, especially the peritoneal endometriosis in a given case? And the patient is infertile. Yes.
It depends on the age of the patient.
Correct.
The preference of the patient. If patient is infertile, we need to see if she's planning to go for fertility.
I think you got muted. Yeah, Saurabh. Yeah.
So it depends on if the patient wants to conceive in upcoming months, or she just want to have the treatment for endometriosis and wait for some time, or maybe like she just want to go for oocyte preservation. So,
yes.
Sir, these are the points where we'll decide whether a surgery should be performed for her or not. And then, sir, when it comes to this thing, size of endometrioma is important. For a size less than 4 centimeter, we would rather prefer to go for medical management or wait for some time. And for anything more than 4 centimeters, we would like to perform surgery.
Yeah. Very true that what you said is very true, that sometimes we'll have to think about the preservation of the oocytes before going for the surgery, which is a very commonly accepted concept nowadays. So let me now ask Dr. Meenal and Dr. Monali about your views that, whenever now I ask this question to Saurabh about the mild endometriosis, but suppose there's endometrioma diagnosed on ultrasound, are you going to do surgery first, or you're going to preserve the oocytes first?
Sir, I'm Meenal
Yes,
Chedgupkar.
yes,
We have to first understand the size of that endometrioma,
correct.
what are the exact symptoms, and is that endometrioma is like according to our infertility assessment is causing any major impact, like if it is coming in between oocyte pickups or what, those things also we have to take into consideration. If usually the size is less than 3 centimeter, we can avoid the surgery and can directly go with the infertility management. But if the endometrioma is more than 4 centimeter, and if it is associated with other problems such as severe pain, dysmenorrhea, then we have to consider about doing surgical management. But everything depends upon the situation, actually what we are supposed to do. If it is a case of adolescent, or it is like infertility case, nowadays the cryopreservation also is very important. If the endometrioma is there and patient wants to postpone their pregnancy, definitely we can go ahead and do ovarian cryopreservation and save her oocytes, because later on there can be recurrences, multiple surgeries, and existing AMH also will decrease.
Yeah, very true. So, very true. She's raised this particular question of preserving the oocyte function, the ovarian function. So, Monali, you do a lot of endoscopies? What I learned, that what tips and tricks you want to give to our audience while doing the surgery for endometriosis in case of infertility? Yes.
Whenever you are
Monali?
addressing the patient of endometriosis, first of all, it all depends on whether you are addressing it infertility or for pain, or for in the age group above 35-40, which have already undergone childbearing age and they have kids. Say if you are taking the case for an infertility and it is an endometriosis case, We all know it is a tip of iceberg phenomena. Whatever things we're seeing, there is a lot many endometriotic pockets deep inside the peritoneum. So once you have posted the patient, you just cannot leave the patient like that. Your target is to have the tubes on the ovaries, remove the debris, give the anatomy properly for the patients. Just what I do is I drain out the endometriomas and I use cautery as less as possible. I try to use
Wonderful.
the cold knife on the cold things and try to preserve the follicles. But yes, draining the endometriomas is one thing which I do and one should always do. And don't try to poke into the deeper things like where you may caught into the ureter or into the bowel or into the other things. So don't go beyond your expertise, specifically in endometriosis case.
Wonderful. That's what actually I wanted to, learn it from you. Very true. The endometriosis surgery for pain is different, for infertility is different. When we have such a wonderful expert with us, Anuradha, Dr. Anuradha Khanna, do you want to put
Yes.
some actually additional inputs on this
Yeah.
endoscopy and infertility and endometriosis?
Yeah. Okay. Am I audible?
Yeah, you're audible,
Yeah.
yes.
Regarding, you have already started the mentioning the etiopathogenesis, how it is affecting the fertility. So here I will say the first thing we see even in ultrasound, the cul-de-sac collection. Even before endometrioma formation, maybe with endometrioma already there, or peripheral this endometriosis. So this collection has got a lot of macrophages which are activated. And this activated macrophages without any block, they are the cause of unexplained infertility because they hamper with the sperm motility and their function and ovum quality. So this is something important. That's why Dr. Kirti or mentioning just now that we see and we treat endometriosis if we have put a laparoscope. Even if we have not put a laparoscope, nowadays with advancing imaging, that is I mentioned about the power Doppler sound, we diagnose and we go with the medical treatment, thinking first 3 months that we are making it like all activated macrophages gone. Similarly, you have also mentioned about the genital tuberculosis. In part of Uttar Pradesh, especially in India, this disease has got a very much high prevalence. And this may be even etiopathogenesis of endometriosis, or it is a sister to live along with endometriosis. Very true. And also the bowel inflammation. Any inflammation in the pelvis, in the abdomen, may be etiopathogenesis of endometriosis because of the environmental, genetic, and epigenetic changes that you have elaborated very, very nicely. And then we are discussing also about the ovarian treatment, cryopreservation. So depending on her economic conditions, situations, it can be done because the girls are nowadays getting late marriages. So it is advisable. Those who are affordable and they are not planning for pregnancy, those who are adolescent, Dr. Ranjana has mentioned, and now later on they are coming with subfertility or infertility, and it is a long disease already have passed 15 years. So why not to have all these things done? And this is very important. But I will never say to go laparoscope as a diagnostic tool. Always imaging is the first for diagnosing the condition, of course, along with a very good history and physical evaluation. And then we have to last is to go for invasive diagnosis treatment also. Don't go for diagnosis. Whenever you put in scope, you should know how to treat because already we know the difficulties in diagnosing and treating the laparoscope. I think
Yeah.
I've said.
Wonderful. It was really a very nice explanation, Dr. Anuradha. And as you said very correctly, when we keep certain things in our mind, we should always and always think about the other, actually the problems as well in the given case. So whenever I release a report of my own endoscopies, as mild endometriosis with suspected genital COGS, I get a lot of criticism as well from some of my colleagues, but I say it's true that there may be some endometriotic implants there actually, which I can see in the form of some red or bluish spots on pelvic wall or uterosacrals, but also I can find some subhepatic adhesions. So probably why not these conditions could be together as well, and we'll have to finally treat that particular patient and we'll have to document it. Your treatment plan definitely gets decided on multiple factors, and that you
Along
can
with
take.
hysteroscopy. Along with
Yes,
hysteroscopy.
yes, very true, very true. Yeah, very nice. So, friends, it's very actually obviously found in this Belgium and the French studies that whenever there's unexplained infertility, there's always undiagnosed endometriosis as well. And many of the cases of recurrent implantation failure, the endometriosis could be the cause behind that particular thing. And so we'll have to increase our eyes on diagnosis of this endometriosis and as well as the management of it properly, as it was told by Dr. Anuradha Khanna very correctly. Now, let me pose in front of you this case. Mrs. AB tried to conceive for 1 year. She's having severe dysmenorrhea, not responding to the painkillers. The husband semen, HSG, AMH, all are normal. How you're going to go further? Yes, anyone? Dr. Pranjal, do you want to answer this because you're not spoken as it now? Yes, Pranjal Madankar is there. Is she there, Dr. Amita?
Hello.
Okay. Hi. Yes.
Good evening, sir. Can you repeat the question, sir, please?
Yeah. Now, how you'll go further in this given case? This is the scenario. I just want to know from you how you're going to go further for this case.
AMH is normal and her husband profile is also normal.
Normal, yes.
And she want to conceive, sir?
Yeah, she want to conceive. That's how she has come to you. Yes.
Her age is not mentioned.
Yeah, she is around 32 years old.
Okay.
Yes, anyone, all of you can give your inputs, which may be contradictory to each other. Doesn't matter, because that is what actually we want to, get from this panel discussion. Yeah.
I'll answer this question. She's 32 years old. Primary infertility, male factor is not there. So her primary complaint is dysmenorrhea. So here there is a strong suspicion of endometriosis. So diagnostic hysterolaparoscopy will be indicated. And accordingly, if it is stage 1 or 2 endometriosis, according to that, the treatment will be given. And for her fertility, that will be a fertility enhancement surgery, depending on which grades. And after that, the patient will be taken for assisted reproductive technologies. So the basic treatment will be either going for an IUI cycle, if everything is normal, or she may also be requiring to go for an IVF cycle, because here the most important factor is her age. She's 32 years old, so that's a very important parameter as far as fertility results are concerned. So the treatment has to be fast tracked in this case, and there will be no role of any progesterone or medical line of management for endometriosis here. So it will be more aggressive type of treatment I will go for this patient. Yeah.
May I interrupt in between?
Yeah, please, Dr.
We have not
Bhattacharya.
mentioned about the imaging.
Yes.
We should have imaging first, because
Correct.
laparoscopy will see only the peritoneal surface. If we do a good imaging, as I mentioned, double contrast Doppler possible, that will let us know all the phenotypes of endometriosis. It's not that we just put a scope and treat it. As already mentioned, it is an iceberg, which we are realizing. So unless until we will not do a good imaging, then how can we go with the laparoscopy is next to that, not laparoscopy alone. I will say laparoscopy because many of the time cervical lesion may be the cause, stenosis may be the cause, septum may be the cause, Mullerian malformation may be the cause. So many things to understand. So a good imaging of whole abdomen, I will say even pelvis, to understand even mesenteric lymph nodes are sometimes involved, a sign of abdominal genital tuberculosis. So we have to evaluate in patient in toto to understand what is the disease, her inside, and then after imaging, of course, laparoscopy.
Yeah, wonderful. Yeah, great input. And that's why I actually wanted to put this particular question to again all panelists about, especially when there is so much advances in the endoscopy, and whenever we follow certain guidelines, we'll have to have our own clinical practice points as well, which need to be implemented in given cases, because guidelines have a certain different scenarios, different actually the epigenetic factors, and whereby we'll have to decide what is suitable in our given case. So, Saurabh, again, as I asked you before as well, suppose the SRM says even for stage 1 and 2 endometriosis, the CO2 laser vaporization or maybe monopolar electrocoagulation if the CO2 laser is not available, or even complete surgical removal before ART are certain guidelines which always get published or various studies get published. I
Yes, sir.
want to ask your actually the practical points, what you do in Jaipur, that what is your thinking about it, and how you go about.
Sir, as you told, CO2 laser vaporizer is not available with everyone because of the cost factors. So
Yes,
monopolar
yes.
or bipolar is the option that we have, and I usually do in my practice. So when it comes to type 1 or type 2 or superficial things, best is, sir, evaporation of with bipolar. Complete excision of the nodule or the tissue is important. If there are any adhesions, complete adhesion lysis is very important. And after surgery, I feel is the post-operative period. We need to consider whether the patient is anxious for issue. If she wants to conceive, we need to put on that patient on GnRH antagonist. Or if she is not willing to conceive, then we can put her on OCPs after surgery so that recurrence is less.
Yeah. Now, suppose you find there is definitely chocolate cyst in that particular given case, about 4 centimeters in diameter. So what will be your say on that? Whether you will remove it, whether you'll do the cystectomy, or you'll just puncture it, as I think even Dr. Anjali was mentioning. So all of you can take this particular scenario and yeah, yes.
Sir, I would like to personally remove the cyst, and then hemostasis is the second important factor that will be considered. How to achieve hemostasis after removing the cyst? There are 2-3 options available with us. One is use of hemostatic agents, maybe like Surgicel or gel foam. And second is cauterization with bipolar. And third is sometimes suturing. So in these three given options, hemostatic agents are the best that will not hamper the AMH levels of the patient much. If you use bipolar or suturing technique, both have documented that there is maybe like 40-45% fall in the AMH level. So that's my way.
Yeah, true. So it's very true that the literature says that cystectomy improves the chance of spontaneous conception, but not the success of ART. The controversial if cumulative surgery rate is more after surgery, but time to achieve the first pregnancy in fertile patients was significantly shorter. There's always a small added risk of oophorectomy because especially if it is done by a not very expert endoscopist. Management should be individualized, and especially we'll have to be very careful about this ovarian function. We need to document it, and carefully we'll have to think about if already patient had previous ovarian surgery. Why I put this particular slide? Because another lady came to my consulting who underwent one adnexa removed for the so-called hemorrhagic cyst, very endometriotic cyst, at one of the gynecologist place. The patient eventually went to another gynecologist who wanted to assess the remaining genital system. So he put a scope, and in another ovary he did the PCO drill because he found that this particular ovary is having the polycystic ovarian disease. And the patient, quite educated, came to opinion to me, say that, doctor, I'm feeling that something is going wrong. Now my AMH is 0.3. So please comment on this particular case where the things could have improved in different way. Yes, anyone can take. Yes,
The
Rajni
first
or
surgery was wrong. The first surgery was wrong. And second
yes,
surgery was equally wrong. The first
yes.
surgery was
It should
wrong by removing the ovary. Second, she should not have done the drilling. She should have done AMH first, taken the consent, talked to her nicely. Both the things went wrong in this case.
Yeah, very true. Rajni, but suppose now this patient comes to you, as she said very correctly, very true. It's such an obvious thing that you suddenly get yourself disturbed. But in this medical legal era, how you will actually comment in such cases when they come in front of you?
So actually, we have to save our colleagues. Actually, I have to answer her that prior AMH level should have been done. Then we could have compared it. But somehow, like with age factor, also like AMH gets reduced, and it is not that particular level that according to not according to age also. So maybe at that level also she may conceive. So we have to give a positive hope too.
Yeah, true. Very true. See, these are the dilemmas in the practice, and same thing happened with me. At one moment, as Monali you said, "Oh my God, I said, what is all this going on?" Because both were quite leading infertility specialists in the city. So what it was a bit difficult to comment on this particular aspect, but yes, we'll have to of course be optimistic and go further rather than going behind. But we'll have to create the awareness, and that's why Ranjana, when you arrange this particular webinar, I was very happy that at least messages to all our delegates will go very clearly about such scenarios, and they will be little cautious while doing or managing these particular cases as well. Now, question comes about the surgery. Which surgery, whether the cystectomy or just to puncture? I think Monal, you were telling that you puncture the endometriomas and you don't go for the cystectomy, whereby Saurabh says you want to remove the cyst. So what are your actually debate on that particular thing? Both of you can answer this. Any other actually panelists also can comment on that according to your experience.
Sir, cystectomy is always preferred over drainage and coagulation because the chances of recurrence are low. The pain relief is better, and there are more chances of spontaneous pregnancy if we are going for cystectomy. So, and it should be done by an expert. Like I had a patient, she was my friend, and she was operated by a surgeon, and he did her oophorectomy instead of cystectomy. And then she had low AMH and she had to undergo an IVF cycle. And so it should be done by an expert laparoscopic gynecologist, not a general surgeon.
Yeah, very true. Yes. Any other comments anyone want to put? Because I
One
know
thing
that
I will
last
say,
3 minutes are remaining.
Dr. Millen, one
Yes.
panelist is saying to save our colleague, we should say, okay, we have to save her. The other panelist is saying, surgeon hai to isko punishment milna chahiye. This is very contradictory. That
Very contradictory,
gynecologist
very true.
should be saved and surgeon should not be saved. After all, both are them of doctors. So we should give a correct message to the audience also that whether it is gynecologist or surgeon, mistake is a mistake. That we cannot say कि आपने एक छोटे से सिस्ट के लिए आपने गोनेड निकाल दिया और आप गलत काम कर रही हैं तो आपको पनिशमेंट नहीं मिलना चाहिए. Seeing a patient rushed for surgery is the biggest mistake. It's a crime, I will say. तो उसको सेव करना है और सर्जन को बुरा कहना है, दोनों ही चीजें गलत है. और we have to so many webinars going on, so many conferences going on, उसके बाद भी इस तरह की mistake तो punishable है, according to me.
Okay, great. Yeah. So friends, last 3 minutes are remaining. We have a lot of things actually in our basket. But let us go a little further because I understand the time is always a constraint for any particular given case. Now I will skip some certain actually the cases here, but let me ask you one very important actually the question related to the medical management after surgery. So what are your views about medical management after surgery in a given case of endometriosis with infertility, not the pelvic pain? It's a case of infertility where you found endometriosis, you've done some surgery, and you want to avoid the recurrence, you want to achieve the fertility as well. So how you go about? Anyone can take case. Pranjal, you are joined for this panel. Rajni, she has come.
I think so. She was there, sir.
She was there. Achha. So Pranjal, you
Yeah.
want to speak on this? Do you give any medical management after endometriosis surgery? Yes. Anyone else? Anjali, you want to answer
Yes,
this?
you can wait for
Sir,
spontaneous.
in case of stage 1 and stage 2 endometriosis, patient should be allowed to try naturally for at least 6 months. And if they are not conceiving, then they can go for an ART, like an IUI or an IVF. But we should not give
Correct.
medical management, because whatever medical management we are giving, it is going to suppress their ovulation. If it's stage 3 or stage 4 endometriosis, then they should not waste time and they should go for ART treatment as early as possible.
Yes. Any other comments? Minal, Vijay?
I've got to comment, Dr. Millen.
Yes, yes, Dr.
In
Amita,
such
yes.
patients where the cycle is okay, AMH is okay, and we are waiting, what used to do in my practice, that second half of the cycle I give darogestan, because
Correct. Okay.
that will have a support to the implantation and also not allowing further progression. It is a supportive medicine.
Sir,
Yes,
I want
very true.
So I want to put one point.
Yes.
What I do in such cases, no, usually I don't treat the patient. I just do the
Correct.
follicular study without induction. And as madam has said, I give the support in the luteal phase.
Yes.
Many patients
Correct.
confused with that. Don't go for stimulation, because otherwise the patient will again have endometrium very faster. Many of my patients have conceived within 6 months just after laparoscopy. Give the support in the luteal phase, just folic acid, monitor the follicles, even though there are some endometrium sitting inside, but there are some follicles coming aside. They give nice follicles and patient conceives.
One more thing.
Nobody
Give her
Yes.
vitamin D. Give her vitamin D.
Yeah,
And
nowadays they are
also
saying vitamin D
measure
for
her
10
prolactin
days.
level. Measure her prolactin level. If it is more than 30 or maybe even 20, I prefer to give cabergoline 0.5 milligram weekly.
Yes, ma'am.
Sir,
Yeah,
I
very
want to
true.
ask one question. If we do endometriosis surgery, can we give the depot Luprodex or something, depot agonist, and then wait for the first cycle, at least for 1 or 2 months? Can we downregulate patient?
No.
That
No.
want to do any infertility treatment for them if they are infertile patients?
Yeah, a very valid question. So who was saying no? I think, yeah. Can you justify, suppose it is stage 3 or stage 4 endometriosis, and
Then it
suppose
is
she wants to,
advisable. Then it is advisable.
yeah, because see, what happens that here we are dealing with not only infertility, also as I told you about the story of that lady from Surat, the pain, which is again there. So we'll have to individualize the case, very true. And that's why, Minal, you are true that in those cases, probably that could be the wise decision to give generation analog. But again, it all depends, because nowadays people say better you cryopreserve those oocytes and then you whatever you wanted to do, because the women are quite aware about this ovarian reserve nowadays, and it is getting affected by multiple factors as well. So lastly, let me ask you about the ART practice and the endometriosis. So again, the question is open for all panelists. Vijay, do you want to start with this? How your IVF practice gets affected with the diagnosis of endometriosis, a case of infertility as well?
Yeah. Whenever the patient has already tried for the other methods and now we have decided to go for the IVF. So the decision for IVF is done. So here, because previous surgery is done on the endometriosis, if the ovary is damaged, the AMH levels go down. So the results are comparatively less in cases of endometriosis compared to our standard IVF cases. So the prognosis will again depend upon the enteral follicular count, the age of the patient, and the AMH level. So if these three things are not good, then we'll not get good results. The second thing we go for is the agonist protocols. We do the egg pickup, and after that we give the freeze all the embryos. We give depot for around 3 months, depot preparation, and after that we go for the frozen embryo transfer cycle. So that is what we do, so that before the implantation we have the regression in the endometriosis, and the embryo is put in a favorable environment. So the problem is because these patients are come late to the IVF center. So already the AMH is poor, the age is more than 32, 33, 34, something like that, and enteral follicle count is also low. So the way you discuss these cases, we get it routinely, and it becomes very difficult for them to explain why the AMH has gone down, because they have underwent so many surgeries. So that is a problem that occurs. So one aspect that is a point of debate between laparoscopic surgeons and the AIT consultant is whether to do surgery first and IVF later, or IVF first and surgery later. So that's $1 million question. The AIT consultants will always go for a pickup, do the egg, the embryo freezing, and then if the patient requires a surgery for endometriosis, the surgery is done, and then you go for the embryo transfer.
Dr. Milind, you have shown a very beautiful slide. That is adenomyosis and GnRH agonist.
Yes.
These are the condition where definitely I give GnRH report. And I will wait, because it takes 3 to 4 months to get adenomyosis more recovered after even laparoscopy, because this is a different aspect. Endometriosis, peripheral endometrioma, they are different than adenomyosis. So once you go for IVF, even spontaneous pregnancy, the environment should be okay, and that is the indication for GnRH analog, whether monthly or depot position.
Very true, yeah. Because see, in those cases again, we have whatever number of embryos preserved with us, we'll have to use them very judiciously, and we'll have to create a very, very positive environment before we put those embryos in the uterine cavity. So as you said very correctly, especially in the cases of adenomyosis, where we know the implantation has its own issues, we'll have to think about this medical management, and then we'll have to go further as well for a given case. Very true. How much time we have, Amita, or should we stop now, or you please tell us?
So we can take one case more.
Okay, yeah. So let me put this particular case in front of you. Yeah. Now this 32 years old lady has been trying for pregnancy for last 2 years. All her AFC, AMH, HHG are normal. Husband is azoospermia. Donor sperms is no acceptable. She has 6 centimeters right ovarian endometrioma, minimal dysmenorrhea. So how you'll go about?
So, if this is the case of infertility, we have to understand if the patient is not ready for donor sperm, investigate the husband and find out if the TISA or TESE is acceptable, and then we have to do ICSI procedure for this patient. And in this scenario, if there is a minimum dysmenorrhea, we can directly go ahead with the ICSI first, and then this 6 centimeter endometrioma can be tackled later by the expert endometriosis surgeon.
Yeah, very true. Exactly. What is the various options we have in front of us? The ICSI, as you said very correctly, or freezing actually the embryos, the oocytes after you pick up, and then laparoscopy, the cyst size increases. If there is pain or difficult, actually the pickup as well when you realize while doing pickup, and then you'll take the further call as and when decided. So friends, I know that infertility and endometriosis are real enigmas in clinical practice, and quite often we realize these guidelines and the various actually options available, so many options in front of us, makes us sometimes confused, but we'll have to think about plenty of things We'll have to think about all technical difficulties while adopting any particular technology. We'll have to think about the disease progression as well, always the risk of infection, follicular fluid contamination, and risk of missing and occult malignancy, which again cannot be emphasized, because I remember at 22 years already having the endometriosis and the biopsy was taken. It turned to be malignancy, and then we'll have to manage her malignancy first before going for further. Of course, after preserving the oocytes as well, and eventually she got cure and got the baby as well with those preserved oocytes. So friends, with this, I think I can stop because a lot of cases are there and a lot of discussions going on. But it's always and always question mark about the management of infertility and endometriosis. So let me ask finally for all my expert panelists one take-home message while managing the case of infertility and endometriosis, which could be practically useful for our clinicians. And as Dr. Anuradha said, before anyone gets the punishment, one has to think about that at least the major blunders are not done. So can you give one line messages to all our delegates?
Only one thing from my side.
Yes.
Whenever you are treating a patient, just think it's your body. And you will
Great,
get all
wonderful.
the answers for it.
Yes,
Nothing
yes,
more
wonderful.
than that. It's
Yes,
your body
yes.
and you are going to treat it. You will get all the
Correct.
answers.
Yes, yes, wonderful. Yes. Others, Dr.
From
Rajani?
my side, let the treatment be tailor-made. Talk to patient, counsel her, give her options, and let her take the decision. And let the treatment be tailor-made for every patient.
Correct. Yes. Yes, Dr. Pranjal has joined, or she is not there. Dr. Monali?
I just now gave my opinion. I said,
Yes,
let it
yes.
be tailor-made. Let it be tailor-made. Give patient all the
Tailor-made.
options. Let her decide. Counsel her properly. Because
Yes, Dr.
endometriosis
Vijay?
is not going to go anywhere. It is going to come back again.
Yeah.
Again.
So in endometriosis, we have to see why the patient has come to. What is the primary complaint? Whether it is pain or whether it is infertility. So if the treatment should be, as Madam has said, to tailor-made, but always consider age, AFC and AMH always, whenever you are treating infertility case, because time is very important. That is what we have realized, because people are treating patients, these endometriosis cases for 3 years, 4 years, and then by the time they reach the ART clinic, they get poor results. So it becomes very, very difficult for IVF consultants to counsel them for donor eggs. So PCO patients with endometriosis lands with egg donation. So that is what happens. So it becomes very difficult. So that is very important. How much time you are going to give for the timeline? That the time to pregnancy is very important, from the onset of treatment to when she becomes pregnant. So that is very important. So when you are thinking on the in terms of managing these cases, yeah.
Yes, Dr. Meenal?
Yes, sir. I want to say, when it is an endometriosis case, and we have understood it, the investigations and the MRI and other things, it is always better to, when we decide for surgery, it is always better to do the surgery with the expert hands. Please don't do diagnostic surgery when you know there is a big endometrioma, and anyways you have to do the fertility enhancing surgery. Expert endometriotic surgeon should operate when it is a difficult case to avoid multiple surgeries in patients.
Very true, yeah. And Dr. Anjali?
Sir, counseling is very important. Patients should be told about the recurrence rates, because many a times patients, they come to you that, okay, we underwent this surgery and then again this is there. So the surgeon doing the surgery should always tell them about what is the recurrence rate, and they should definitely fast track their treatment for infertility if they have low AMH along with endometriosis. Then they should not wait for for natural pregnancy to happen. They should definitely go for an ART treatment if their AMH is low.
Always think of medical legal issues.
Yes.
Yes.
Yes, Dr. Saurabh Bhargava. Saurabh, are you related to Dr. Adarsh Bhargav?
Yes, sir. She is one of my aunts. Yeah.
Oh, great, because she was very active member of my committee in those days, and I had so many actually inputs from her in my committee actually years of 5 years. So when you corrected your name, Saurabh Bharadwaj to Bhargava, I realized you must be definitely related to Adarsh. Yes. So great. So your take home message to our audience.
Two things. One is treatment should be tailor-made, and
Yes.
the clinician should know his pros and cons. If they are good with medical management and patient is fit for medical management, they should proceed with it. If patient requires surgical management and the obstetrician is not very good with his skills, his or her skills, we should not operate upon that patient and send the patient to some other person. I have worked with Dr. Hafiz Rahman sir for 6 months, and there we had a lot of patients coming from all over India who have been operated once earlier, and the second surgery for those endometriotic patients are very difficult. So, sir always used to tell us one thing: the first surgery for endometriotic patient is the best thing what you can do. If you cannot perform well, do not do it, do not touch it. But if you are doing the surgery, you should complete the surgery 100%.
Yes, very true. Yeah. Thank you very much, all my very expert panelists. Yes, it's always little dilemma when we want to choose between these two, surgical or the medical. But yes, definitely we'll have to go ahead with all those things. And as you all know, that there's so many guidelines which are getting all the time revised, putting more and more evidence based actually the understanding about the particular disease and the particular scenario, or for which the patient is coming to your consulting room, and you'll have to take the decision. So thank you very much, Dr. Ranjana, Dr. Amita, the ISOPARB Prayagraj, because it's indeed a pleasure to be part of this ISOPARB. And friends, now the ISOPARB is getting more popular in the international, actually the scene as well, because as FOGSI is affiliated to FIGO, ISOPARB is affiliated to FOPS, and we want to inculcate more and more research for that. So anyone of you are interested, please contact. Fortunately, I am working as a Secretary General for the FOPS. I want to bring all those research from India to the Asia, Oceania, actually countries, whereby your inputs will be definitely useful for not only Indian women, but also all those unfortunate women who present to various clinics with either in endometriosis and infertility. As we get our results of this particular study which we are doing ICMR, I'm definitely happy, will be happy to share with you all, and probably who knows that we'll be having more genetic actually the aspect which is related to endometriosis. So thank you very much all the societies as well, the Allahabad, Yavatmal, Amravati and Solapur society for this wonderful opportunity. We are going to go a long way when it comes to the diagnosis of endometriosis as well as the management, and especially if there is infertility. Again, things are definitely going to be different as well. Thank you very much, and Deepika, thank you for your coordination for all this entire webinar. Yeah, thank you.
Thank you very much, Dr. Millian, for your such a wonderful panel discussion, and very nice. Our esteemed panelists, all of you did a wonderful job. My best wishes to my dear friend, Dr. Ranjana Khanna, for her participation, for to be elected as a FOGSI president. All my best to you, dear Ranjana.
Thank you so much. Thank you so much, Anuradha.
Yes.
Thank you so much, sir. Thank you so much, Anuradha ma'am, and all the expert panelists for a wonderful panel on infertility. I now request Dr. Amita Tripathi to propose the vote of thanks.
Since there is very less time, I'm going straight, and there is no question in the chat box, so I'm going straight forward to the vote of thanks. After this stimulating scientific evening, the time has come for formal vote of thanks. First and foremost, I want to thank Dr. Suvarna Khadilkar for her gracious presence and blessings. I can't thank enough the societies, Amravati Society, Allahabad, Solapur, and Yavatmal for joining our hands. I want to thank ICOG office for always giving us ICOG points. I extend my heartfelt thanks to our chairpersons, Dr. Rashmi, Dr. Sushma, Dr. Charutha, and experts for the panel, Dr. Anuradha Khanna ma'am, and our own scientific expert, Dr. Manju Varma ma'am, for your valuable inputs and giving this webinar a wonderful hue and flavor. Words are not enough to pay my gratitude to our speakers for today, Dr. Khanna ma'am, for her stimulating talk as ever. She is a lady who has given much glory to Allahabad Obstetrics and Gynecological Society and ISOPARB Prayagraj. Today, my earnest request to all of you to vote and support for her candidature for the prestigious post of President FOGSI. And I believe and I am very confident that she will leave no stone unturned to bring glory to the FOGSI always. So my request to all of you to support her candidature. My sincere thanks to Dr. Pushpa ma'am for her very informative talk with so many take-home messages. And my heartfelt thanks to Dr. Milind sir for this very exciting panel. As usual, listening to him is always a treat. My sincere thanks to all the panelists, Dr. Monali, Dr. Vijay, Dr. Rajni, Dr. Minal, Dr. Anjali, Dr. Saurabh, Dr. Pranjal, for keeping this panel very interactive and very practical. And you all have given us so many very clear-cut take-home messages. Thank you so much. Thank you, Parul, for co-moderating with me. And thank you, Jagsonpal, especially Dr. Deepika, for always supporting us and giving us a wonderful platform. Thank you, all the delegates, for joining us from far and wide. And thank you, all the societies. Thank you so much.
And thank you, Dr. Anuradha Khanna, ma'am, for your wonderful expert comments all the way.
And thanks to dear Amita also. She's so vibrant. She takes so much of care, everyone's care. A big congratulations to you, Amita and Parul.
So I take this opportunity to just bring to you a few of our products which are also being prescribed by all of you for endometriosis. We have Dynogest 2 mg tablets, the first people to bring out the tablet formulation as EndoReg. Jagsonpal was the pioneers in the tablet formulation of Dynogest. We have DeeReg, the combination tablet. Again, Dynogest 2 mg with ethinyl estradiol 30 mcg. And Divatron micronized dydrogesterone. We also have the SR formulation in 20 mg. So for endometriosis, these three products were being discussed during the webinar. I thought it appropriate to highlight over here that the products are available. Please continue to give us the support.
Sure.
Apart from this, I bring to you another opportunity where we can all, be a part of public awareness programs for the public, for the society. This is our corporate social responsibility, the CSR initiative, which is mysakhi.in, which is our website, which has been recently formed. So we have a lot of women health kind of literature information for the public, from adolescent to reproductive health and menopausal women. There's a lot of educational content, also community engagement we are doing, and we are having some expert guidance and additional resources for them, and having these public awareness programs for the public and inviting the public for these events. So till now we had been doing on menopause, and now we've started to go in for pregnancy. It would be wonderful to have one for endometriosis too, because that's a very, very popular problem that is right now the public is very much getting interested in. So do join us for these live interactions, and you also be a part of our public awareness initiative as experts, and give us support. So thank you all very much, and we look forward to being with you again in the next Scientific Sangam, organized by ISOPARB Prayagraj.
Thank you.
Thank you.
Thank you.
And best wishes to Ranjana Khanna ma'am, as always.
Yes.
Thank you, dear. Thank you.